I would like to talk about the lung cancer screening and mainly in Asia. As you know that the lung cancer is a main problem, health problem worldwide, but there is a difference between the developed countries and developing countries in terms of the population and the patients' history. If we look at the Asia snapshot, you can see that across the country in Asia, we have a lot of lung cancer problems, including China, Singapore, South Korea, and Thailand that we illustrate here. It is a common cancer death in Asia, whether it's a first, number 1, number 2, or number 3. And if you look at this graph, you can see that the survival rate of lung cancer is 5-year survival is quite low. The highest is in Japan, and that 5-year survival is 36.7%. And the reason behind that is because in Japan, they can diagnose lung cancer 36% in stage 1, meaning that the patient has access, or the population has somehow screened and can get diagnosis in stage 1 disease compared to other countries. And we all know that if we diagnose a patient in stage 1, the chance of having 5-year survival is 90% or more, or can be 100%. But if we diagnose a patient in stage 4, then the survival rate is around 10%. So that comes to the value of lung cancer screening. In Asia, we talk about the population, the pollution, and we all know that the air pollution, especially PM 2.5, that induce the EGFR mutation in the alveolar epithelium cell, and that can promote the lung cancer, especially adenocarcinoma. We have seen this across the country in a patient who's non-smoker. In this slide, in Thailand, we basically just lost a doctor who basically just finished the residency 3 years ago, and he was diagnosed with stage 4 lung cancer. And before he died, he actually the one who basically promote the lung cancer screening. This is a study mainly from Taiwan that illustrates the difference between the lung cancer patients in Caucasian and Asian. In Caucasian, the underlying mutation is KRAS, and EGFR is around only 15 to 25%, and 80% of the patients are smokers. But in Asian, the KRAS mutation is lower, account for only 8 to 10%, and the very high EGFR mutation, 55 to 60%, and most of the patients are non-smoker female patients. And the reason behind that is because of the pollution that change the mutation in the alveolar epithelium cell and make it susceptible to develop the cancer, especially adenocarcinoma. There are multiple studies that can explain the pathophysiology of this mutation in non-smoker patients. Very first study about National Lung Cancer Screening Trial showed that the lung cancer, a low-dose CT scan can detect early lung cancer and provide 20% mortality reduction compared to the chest radiograph. And since then, there are multiple studies that support the low radiation CT scan, and many authorities recommend the low radiation CT scan in that population. This slide summarizes the major low radiation, the CT scan lung cancer screening. And you can see the first one is National Lung Cancer Screening Trial that can detect around 1% of lung cancer in the study, and with the 20% mortality reduction. Then it comes to the Nelson trial, detect around 0.9% of lung cancer with 24 to 30% mortality reduction. And then after that, there are multiple studies, including Dante, Italian, Lucy, and UK. And you can see that the rate of lung cancer detection is around 1 to 2%. And the mortality reduction is around 20 to 30%. Now, if we look at the Asian study, this is the very first one about the lung cancer screening, and that study in non-smoker patient. So in this study, it includes non-smoker 55 to 75-year-old with lung cancer risk, which basically they include the family history of lung cancer, passive smoking, and cooking index more than 110. So basically, if they cook inside the closed space, whether it's Asian cooking, the stove, or the gas, basically, if they stay in that kitchen for a period of time, that cooking index is more than 110. Or cooking without ventilation, that's also counted as a risk. In those patients, they get the chest X-ray, and then they randomize to get the standard CT scan or radiation CT scan, depending on the chest X-ray result. And then if there's something fine in the CT scan, then they will get the biopsy or follow-up. This study is an ongoing study, but it reports the first year result. And this is the first year result. You can see that the lung cancer detection rate is 2.6%. It is equal to smoker patients, and it is equal to a developed country that many studies in the past that include the smoker patient, but this is non-smoker patient. And the invasive lung cancer is around 2.1%. 96% in lung cancer patient in this study is stage 1. And in this graph, you can see that if the family history, the first degree relative had lung cancer, the chance of that person having lung cancer is higher. And if that person has at least 3 first degree relative of having lung cancer, then the chance of having lung cancer in that person is 3 times higher than the normal population. So in this study, it confirmed the risk factor of family history, first degree relative of having lung cancer in non-smoker is a risk factor of having lung cancer besides the smoking. And this slide compare the previous study with the NLST. And you can see that in the Taiwan study that include 12,000 patients, and the positive screen defined as a solid nodule more than 6 millimeter or ground glass nodule more than 5 millimeter, compared to the NLST that defined as a positive screen of nodule more than 4 millimeter. You can see that the cancer detection rate in the non-smoker patient is higher than the NLST. So in the non-smoker patient, the cancer detection rate is 2.6% compared to the NLST, which is 1.1%. So non-smoker patient, even though they are not smoker, but they also at risk of having lung cancer, given the pollution in this area. This slide shows that the number needed to screen to detect one lung cancer compared to other screening tools. You can see that in colon cancer, the compliance is 68%, and number need to screen is 1,250 colonoscopy to detect one colon cancer. But if you look at the lung cancer, number need to screen is only 320 cases to detect one lung cancer, which is lower than the colon cancer, cervical cancer, and breast cancer. So it's important for us to know that and to promote the more screening to reduce mortality of the lung cancer in the Asian area. Okay, if we can do this lung cancer screening, then we will detect more stage 1, and obviously we can reduce mortality. The concern about the Asian population is the radiation exposure from lung cancer, LDCT. And in this slide, show that the LDCT is actually quite safe in terms of radiation exposure. It's a little bit higher than mammography, chest X-ray, and air travel more than 10 hours. So basically, LDCT itself is quite safe in terms of radiation exposure. In this slide, it summarizes the Asian screening recommendations from Korea, China, Japan, Singapore, Indonesia, and Taiwan. And you can see that most of the Asian recommendations still relied on the previous published study that include the smoker. But given the new data from Taiwan, and you can see Taiwan, they also recommend LDCT screening biannual for the high-risk individual. And that high risk does not mean the smoker, but it means the patient, the person who has a first-degree relative of having lung cancer, or the cooking index more than 110, or cooking in the close ventilation. In Asia, there are multiple barriers of lung cancer screening. Number one, it was perceived as a tool for screening for the smoker patients, which is now, it need to be changed to a screen for the high-risk non-smoker patient. The screen is associated with a very high positive or false positive results, including the tuberculosis, which is prevalent in the area. And it can, and with the limitation of intervention to diagnose that positive results, it made this LDCT become more difficult to implement. Okay. And the further procedures which already required after a positive result of LDCT, and as we all know that the procedures and the intervention to diagnose that in positive result is limited in the area. But and the adherence of lung cancer screening from the patient is also poor. Okay. In conclusion, lung cancer is prevalent in Asia, in non-smoker, and it is the leading cause of death. LDCT is useful and is proved to detect lung cancer patient in non-smoker who has risk of having lung cancer. The LDCT benefit both smoker and non-smoker, and the current guideline need to change to include the patient who is non-smoker but with risk of having lung cancer. We need to improve the poor adherence and perception of the patient to get more LDCT. Thank you very much.